From the heartland of the United States and one of the leading children's medical centers in the world, welcome to the Children's Mercy Kansas City Pediatric Bioethics webinar series. We invite international leaders to discuss critical and controversial issues in bioethics. Now, from the Bioethics Conference Center on the Adele Hall campus, here's Dr. John Lantos.
Welcome back, everybody. It's great to be here in the Bioethics Tower with a wonderful webinar for you today. Before I introduce Professor Ross, let me remind you of a few upcoming events. March 23rd and 24th, there's a nursing ethics conference at UCLA. It will be pediatric and adult nursing, critical care, and general nursing. It's going to be a wonderful event. If anybody's out in California or wants to go, sign up for that, March 23rd and 24th. April 6th and 7th, here in Kansas City, our 8th annual conference on pharmacogenomics and personalized medicine. We have some great cases with great discussants dealing with some complicated issues in genomic testing and screening of newborns, so you'll want to get here for that if you can. Two upcoming webinars. James Mumford will be here on March 27th and Larry Churchill on April 3rd. So we have a lot going on here in bioethics. Sign up for any or all of those. It's a great pleasure today to introduce my old and dear friend Lainey Ross, who is the Carolyn and Matthew Bucksbaum Professor of Clinical Medical Ethics and a professor of, get this, pediatrics medicine, surgery, and in the college at the University of Chicago. She's the associate director of the McLean Center for Clinical Medical Ethics. She's written numerous books. I have her first one here, Children, Families, and Healthcare Decision Making. She's also written a book on children in medical research and two recent books written with Robert Veach, one on defining death and one on transplantation ethics. But today she's going to talk to us about mitochondrial transfer technologies, science, ethics, and politics. For the people online, remember, Lane will talk for about 35 minutes, and then there's time for questions. If you have a question or a comment, type it into that chat box at the lower right-hand corner of your screen, and we will read those out. Thanks for coming.
Thanks for inviting me, John. It's great to be here. So just to begin, I have no disclosures. I have three objectives for today's talk. The first is to provide a background of mitochondrial biology. Then I want to explore the history and ethics of mitochondrial manipulation and replacement technologies to both overcome infertility as well as to prevent mitochondrial diseases, with my focus mainly on preventing disease. And then third, to examine the first in human case study. So just for a sort of a brief overview of the biology, so all human cells contain two genomes. The one we mostly think about is the nuclear genome, containing somewhere between 20 to 30,000 genes. And that's associated with most of the physical traits and attributes that we identify when we think about individual identity. And remember that half come from the female gamete and half come from the male gamete. The mitochondria only contains 37 genes in comparison, so much, much smaller, and 100% is transmitted from the mother, so the female gamete. There are a few mitochondria in the sperm, but they are targeted for self-destruction. However, there are actually 1,100 genes required for the mitochondria to function. So what we're seeing then is that you have to have interactions between the mitochondrial genome as well as the nuclear genome. And that becomes very important as we think about transferring or replacing just the mitochondrial DNA. So what are mitochondria? What's their purpose? They sort of think of them as the batteries of the cell. They're the ones that make ATP through oxidative phosphorylation. What's important to know is that we have different number of mitochondria in different cells. So red blood cells have none, whereas liver cells have thousands, and there are over 100,000 mitochondria in the eggs. So the first attempt at manipulating the mitochondria, I'm going to use this picture, is that what you see is you have a patient oocyte or egg, and you have a donor egg. And the patient has infertility. And what the theory was back in the early days when they were trying this in the 1990s was actually to remove some of the cytoplasma from the donor and then just literally push it into the patient's oocyte. And then with IVF, create embryos, and the hope was that this was going to reduce infertility. So as I said, this was originally attempted in the 1990s, and they actually had 30 successful fertilizations with 13 conceptions. Now, unfortunately, 2 of the pregnancies had chromosomal abnormalities, one of which was miscarried and one of which had an abortion. One child, so remember, this is only out of 13, one child was diagnosed with pervasive developmental disorder. And what's interesting is only 2 were known to be heteroplasmic. What we mean by heteroplasmy is that it was known to have mitochondrial DNA from 2 sources, in contrast with homoplasmy, where you can have just all the mitochondrial DNA of one type. So we don't know about the other 11, whether they actually were heteroplasmic, whether the technique actually worked. And we'll talk about what little we now know 20 years later. So given this early data, which was pretty discouraging, in 2002, the FDA Advisory Committee raised 2 safety concerns about the attempt of mitochondrial manipulation. And their concerns were, first, the possible inadvertent transfer of cellular constituents like chromosomes, and therefore causing abnormalities in the embryo and then fetus. And the second was the possibility of enhancing survival of those who would have significant birth defects. So because of that, they actually halted the procedures, and no further systematic follow-up of the children was ever done, which is why we don't even know if heteroplasmy was actually achieved in most of those pregnancies. Now, interestingly, in 2004, an abstract was reported by Chinese scientists who claimed that doing this technique actually improved pregnancy rates and reduced spontaneous abortions. They report 20 live births, but they don't tell us what the denominator is. And again, there was no follow-up on these children, so we don't know if there was heteroplasmy in their mitochondrial DNA, which would be important to know, because then you would want to follow to know what type of long-term outcomes to expect or not. So we then move from the notion of treating infertility to actually to the treatment or prevention of mitochondrial diseases. And just to put it all in perspective, this is all really recent, after I graduated medical school. In 1988, Wallace and colleagues reported the first identified human pathogenic mitochondrial DNA mutation, which was the cause of Leber's hereditary optic neuropathy. So mitochondria can be heteroplasmic even without doing any manipulation. So women can have multiple types of, they can have both abnormal mitochondria as well as healthy mitochondria, all of their cells. And you have to reach a certain threshold of abnormal mitochondrial DNA for disease to present. So if you have a very low level, you may actually have, as I said, pathogenic mitochondrial DNA, but be totally healthy. And about 1 in 400 have maternally inherited mutations in their mitochondrial DNA. The problem with mitochondrial diseases is that they're very clinically heterogeneous and difficult to predict onset. They're also very rare and even very difficult to diagnose. But different quantities of pathogenic mitochondria can be in different organs of the same individual. So one of the things we don't know, and one of the most important things about this whole talk, is what we don't know. The unknown unknowns is also important. But what we know that we don't know is why do sometimes the mitochondria that are mutated, why do they replicate so much faster, so that even somebody who's heteroplasmic, having both healthy and mutated DNA, can actually have children who have all abnormal DNA. And so we don't understand why sometimes they replicate faster, and we also don't understand why in certain parts of the body sometimes the mitochondria healthy replicate faster and in other parts slower. The other thing to realize about mitochondrial diseases right now is that there are no cures and everything is symptom-based. So the whole idea of mitochondrial transfer technology is, in a sense, to avoid the issue by getting rid of the mutated DNA. So there are 2 different techniques that are being used for mitochondrial replacement. They're called pronuclear and spindle transfer. And what you can see on the top, the pronuclear, is what you have is, again, you have a donor and a patient egg cell. And then you fertilize it with the intended father's sperm. So you're fertilizing both. So now you have a fertilized egg with the intended parent on the bottom, and a fertilized egg with the donor egg and the father's sperm on top. And then what you do is you remove the karyoplast, which is mostly the pronucleus, so mostly the nuclear DNA. But when you remove that, you also do get some cytoplasma, so you will get some mitochondria from the patient's cytoplasma. And then you're going to take the patient's pronucleus, which again is the intended mother's DNA with the father's DNA, and you're going to, in a sense, refuse it into the donor's egg. So you're going to have mostly, the cytoplasm is mostly mitochondria from the donor, although, and it has the pronucleus from the intended mother and father, but it also has a little bit of mitochondria from the intended mother. So therefore, we are still in what we call heteroplasmy. And so again, one of the issues is which of the mitochondria are going to replicate.
So, Lainey, the donor is just an unrelated volunteer here.
Correct, and that actually becomes a big issue because how much matching you want to do of donor and patient. Do you want them, for example, to be from the same ethnicity? Because remember, there's going to be a lot of interaction. 1,100 genes are going to be necessary to create the batteries of the cell. And we don't know what happens if you replace just the mitochondrial DNA and they no longer sort of match the nuclear DNA. And so that's actually one of those other unknowns, absolutely unknown. And when we do research on animals, we often have very inbred animals, so we really can't even test some of those hypotheses in animal models.
Okay.
The difference with spindle technology, so we're doing the same thing except we're doing it at an earlier stage. We're actually removing the karyoplast before it's been fertilized. So we're only taking out the intended woman's DNA. And the advantage of that technique then is that you're not actually creating an embryo that you're going to destroy. But otherwise, it's the same thing. You're removing the karyoplast, re-implanting it into the donor's cytoplasma, then you're fertilizing with the intended father's DNA and creating a zygote. So the real difference here is whether you take it when it's just an unfertilized or a fertilized egg with the pronuclear requiring the creation and then destruction of an embryo. So in February of 2014, the FDA had a briefing document by the Cellular Tissue and Gene Therapies Advisory Committee, and it was called Oocyte Modification in Assisted Reproduction for the Prevention of Mitochondrial Disease or the Treatment of Infertility. And what they were really looking at were safety considerations. And they said we need to establish criteria to select the eggs and the embryos before and after manipulation. We also need to establish criteria to assess the quality of the transferred material. They acknowledge the potential for inadvertent damage to the manipulated oocyte embryo as you're removing the karyocyte. They talked about the carryover, that you are going to get some cytoplasma from the intending mother's mitochondrial DNA, and again, whether that would replicate quickly and therefore cause disease in this new embryo. It also, unlike traditional IVF, fascinating that we can call it traditional at this point, but it is over 30 years. It requires reagents that aren't needed in conventional reproductive technologies because you are breaking into the egg and you then need to refuse the karyoplast back into the cytoplasma. And no one knows what risks and health risks that might have for the developing embryo as well. So at their request, they actually asked what we used to call the IOM, but now the National Academies of Science, Engineering, and Medicine, to convene a committee to examine and analyze these ethical issues. And that report came out in March of last year, so almost a year ago today. And there were several important ethical issues that were raised, and the first is that this technique is going to create and use embryos for research. And particularly with the pronuclear transfer, you are literally need to create an embryo that you're then going to discard. So that raises the ethical issues of creating embryos. In the US, we actually don't have a system for any regulation for the creation of human embryos. They do in the UK, and we can talk about how that affects both practice, research, and policy. You can use some degree of leftover embryos, but what's also, so those that are not used for IVF transfer after pre-implantation genetic diagnosis. And so therefore you can actually study human embryos that have mutated DNA and trying to understand, again, why some of these mutated DNA replicate so quickly. So the second big issue is crossing the germline. So a lot of research to date has been in somatic cells, so cells that aren't going to, in a sense, be part of the generation of a new generation of children. And so the germline are the sperm and egg that get passed on. And so there's the whole question, is this playing God? Because in a sense, we are interfering with the sperm and egg that create the next generation. Now, you could argue that all assisted reproductive technologies falls on this slippery slope, but most of them don't require, in a sense, manipulation as this does. So there's concerns from the disability communities that, that this will have adverse stigma for those with disabilities and that this is an attempt at eugenics. And this is actually, there's been virtually an entire world ban, or at least discouraging, of germline manipulation. So 3 ways have been sort of ways to think about it have been used to attempt to sort of get around the whole issue of germline. So what they've done in the UK is to argue that when we're talking about germline, we're really talking about nuclear DNA, and we're really not talking about these, dozens of cytoplasmic DNA. And that's their solution. And so they feel that this isn't crossing the germline because it's not affecting the nuclear DNA. Another attempt has been to distinguish between, you're really not manipulating the mitochondria per se, you're just replacing it, so view it as a substitution. But nobody has actually successfully used that argument for a policy change. And the third way to try to sidestep these bans is what the IOM committee came up with, which was to define the germline only to refer to genetic material that is inheritable. So remember that you get 100% of your mitochondria from your mother, which means then that if the only embryos we create with this technology are male, then if the males go on to become a child, who then becomes an adult and reproduces, there will be no transfer of his mitochondria. So in a sense, it's a one-generation issue and becomes, in a sense, non-germline. And that's actually the solution that was proposed by the IOM committee, to just create male embryos, at least at the beginning, until we truly understand some long-term safety data. Regardless of what you call it, there is genetic material coming from 3 sources. There's the intended woman's nuclear DNA, the intended father's nuclear DNA, and the mitochondria from this third source. Now, language matters. Should we call all of them parents? So the hype of the, quote, 3-parent embryo. I would actually argue that it's more accurate to call them all providers of genetic material and leave the label of parenthood for those who will actually raise the child. And of course, in some of our IVF, we have donated eggs, donated sperms going into a surrogate planning to be raised by totally non-genetically, non-gestationally related adults. And I would argue the people who are intending to raise are really who the parents are. And so that it's inaccurate and it's sort of hyperbolic to call all of these genetic sources parents. But regardless, we do have, as I said, DNA contributions from 1 man and 2 women. And so we need to think about what impact that might have on the child's identity. So again, I mentioned that in the UK, they want to argue that the only germline material is nuclear. So even though in the UK, adopted children starting from the age 16 on are allowed to go to a registry and find out who their genetic parents are, while they're going to keep track of who the donor mitochondria belong to, they're not going to release that information. So individuals will never be able to find out whether they were born by this technology, in their way of saying they really aren't parents, quote unquote. But the idea that you have DNA from 1 man and 2 women is interesting because of kinship issues. So one of the things, if you were to go online and try to find out your identity through 23andMe, for example, sending off a saliva swab, one of the things we use is using the female, using the mitochondria to determine who your female great-great-great-great-grandmother is. And we know there's something like half a dozen to a dozen Adams and half a dozen to a dozen Eves from whom we're all descended. But imagine, as we'll see in an example, that your donor egg is from a woman from Mexico and your intended mother is a woman from Jordan. You might have a mismatch, and yet if you were to send your sample off to 23andMe, they would think that you were of Mexican ancestry, even though we're only talking about 37 rather than the 20,000 nuclear DNA. Why I use that example will become obvious shortly. So it's interesting because we want to deny that there's any genetic relationship. Meanwhile, the way we look to identify kinship and genealogy is through the mitochondria. So the third issue, of course, still goes back to the first question that was asked by the FDA, is it safe? And so let's just look at a little bit of preclinical data. So here is Mito and Tracker, and they're shown to be healthy at 3 years of age, and they were actually born by germline gene therapy of inherited mitochondria, and this was published in 2013 when they were 3 years old and healthy. So this is very reassuring. The problem is that this is going to be their new mitochondria for life. So do we need to sort of watch them age? And of course, not only just watch them age, but watch them reproduce and see the health of their children and grandchildren. So there's a long way to go to say that this is absolutely safe. And in fact, what we'll be able to say right now is that it's not unsafe, but no one's willing to actually say it's totally safe. There are other animal studies actually that should give us pause. And this is really important. So they've done lots of studies with everything from mice to Drosophila. And what they have found is that some of these animals have reduced male exercise capacity, that some have infertility, that some don't learn as well, that some have abnormalities in aging. Now, there are many reasons to explain why these data do not extrapolate well to humans, in part because we're not heavily inbred mice species as lab mice are. But yet, the fact that there are all these health problems that can be picked up within one generation really does need to give us pause, and gets back to that issue of, do we need to do some matching of the mitochondrial DNA and the nuclear DNA? And that answer to that right now is just a big question mark, if that's actually the cause of why they're not healthy, or if there's some other reason, and we really just don't know. So there's some human data that should also give us pause, and this was data that published by Egley's group last year. And so one of the things it shows is that if you look at the right-hand corner, you'll see that they're taking a biopsy of the embryo that was created by pronuclear transfer. And you'll see that the result is you have one with all green cells, which are all healthy mitochondria, and the other is a mix of red and green, which has both mutated and healthy DNA. And so the problem is that if you take a biopsy, you're only getting one sample of one cell. And as I've already mentioned, different cells can have different percentages of healthy versus unhealthy. So you're not really sure that just by biopsying and getting a good result means that the resultant embryo slash fetus slash child is going to have mostly healthy mitochondrial DNA. You also have to remember that even within one individual, different organs will have different percentages of mutated DNA. So that in itself, even if you pick sort of the embryo with the fewest amount of mitochondrial mutated DNA, you don't know what's going to happen during the replication process of millions to billions of times. What we can all say is that you have to have a threshold of abnormal mutated DNA before you start seeing health problems. But what that percentage is and whether it differs in different organs, again, just a big question mark. So the fourth ethical issue raised by this is the whole question of, how do you decide that it's safe enough that you're willing to try it in humans? And when you're ready to try it in humans, how do you get informed consent from the intending parents? And so clearly we need to think about the issue of informed consent. So here we need to talk about the risks, the benefits, and the alternatives. So what are the risks? Well, we have risk to the intending female parent, the nuclear DNA provider, and the risk to the egg donor, who is the mitochondrial DNA provider, right? And the risk to the intended parent is the failure to become pregnant, the failure to carry a pregnancy to term with a live, healthy child, emphasis on healthy as well as live, and then the toxicities of the reagents used. So while we can say that IVF is really relatively safe, we don't know, because this technology uses these new reagents that have never been used before. The risk to the egg donor is one that's often not emphasized in IVF technology, but you can get ovarian hyperstimulation syndrome that can be really quite painful, but also even life-threatening. There's always surgical complications that occur. And we're really concerned about potential long-term risks of egg donation because of the stimulation and whether that may lead to health problems in the long term. There's also the risk to the male partner in the sense of the failure to achieve a viable pregnancy of a live, healthy child. So those are the risks. The potential risks to the child to be, you have the mitochondrial disease due to carryover of the abnormal mitochondria. Again, anytime we take the karyoplast, some of the patient's mitochondria cytoplasma gets removed with the karyoplast. There may be disorders due to nuclear mitochondria incompatibility. It has been seen in animals. We're not exactly sure how that will be affected in humans. There's disorders related to aberrant epigenetic modifications. We may see birth defects and other disorders associated with the manipulation. And again, this toxicity of the reagents and what effect it'll have on the child to be. And finally, the alternatives. Well, what are your benefits? So what are the benefits? You can, the benefit is obviously a healthy child, genetically related, nuclear genetic related. For the egg donor, the benefit is helping a third party achieve her goals of having a successful, healthy, live baby. And there's probably going to be financial compensation for egg donors. And for the child, it's the chance to be born with a lower risk for mitochondrial disease. Again, not a zero risk, but a decreased risk. But how low is low enough to only time and attempts will show. And finally, what are the alternatives? So a woman has basically 6 options, right? She can do unassisted reproduction and just see what nature gives her. She can do unassisted reproduction with prenatal diagnosis. She can do IVF and preimplantation genetic diagnosis. She can do IVF with egg donation, embryo adoption, or adoption. And each of these have risks, right? So the unassisted reproduction, she has the risk of having a seriously affected child. That's the whole reason why we're talking now about mitochondrial transfer technologies. With unassisted reproduction, you can do prenatal diagnosis, but remember, wherever you biopsy, that's just a random part. Unless you have homoplasmy, meaning all your DNA are the same, mitochondrial DNA are the same, you really don't know how much heteroplasmy you're going to have in different organs in different parts of the body. Same true with IVF and preimplantation genetic diagnosis. Even though you're doing it at an earlier stage, you're only taking one cell, and you don't know if you have one that is sort of an average of the other cells or is an aberration. And of course, what if you find out that all of her mitochondrial DNA are pathogenic? Then this technology is not going to help her at all. Finally, with IVF with egg donation, I mean, here the issue is that the intended mother has no genetic relationship to the child who's going to be born. She may still have a gestational relationship. When you do embryo adoption, neither intending parent has a genetic relationship, but again, the woman can still have a gestational relationship. And finally, with adoption, there's no intended genetic nor gestational relationship. And clearly, people are doing this, thinking about this procedure, developing this procedure, because women and couples really want to have a nuclear genetic relationship with their future children. So where are we? So what happened? In pre-2008, there were rules against modifying gametes in embryos, but in 2008, the Human Fertilization Embryology Act was amended to permit altering mitochondrial DNA of an egg and or embryo used in conception to prevent transmission. And in fact, in 2014, the HFEA encouraged Parliament to introduce new mitochondrial donation regulations, which were approved in 2015. And at that point, they recommended additional studies before licensing a clinic to actually transplant these embryos into a woman for an attempt at an intended pregnancy. In the U.S., in 2016, when this report came out, the feeling was that we're not ready yet, that clinical trials should wait until we have proven initial safety is established, with the main focus on minimizing risk to the children. They wanted to make sure that the likelihood of efficacy was established by preclinical research, so more animal research. They wanted to limit this technique to women at high risk of transmitting a serious mitochondrial DNA disease, and not, for example, to older women who might want this for an infertility treatment. They wanted to limit it to male embryos so that it would stop at the first generation. And they wanted to limit it to centers and investigators with significant demonstrated expertise. Now, we have a committee in the U.S. called the RAC, the Recombinant DNA Advisory Committee, which does provide oversight of gene transfer technologies. However, as a matter of policy, they will not review any research proposals that seek to modify gametes or embryos. So we're going to need some oversight, so we may have to either change the regulation of the RAC or create another committee that will do oversight, sort of like the HFEA from the UK. Now, one problem is that in 2016, there was also passage of legislation which stipulates specifically, quote, none of the funds made available by this act to the FDA may be used to review or approve an application for an exemption for investigational use of a drug or biologic product in which a human embryo is intentionally created or modified to include a heritable genetic modification. So at least with this legislation, it's impermissible to actually do any oversight in the U.S. currently. So all the cautionary steps went out the window, though, on September 27th of this past year, when it was announced that, quote, this is the world's first baby born with a new three-parent technique. So again, the sensationalism of a three-parent technique. What do we know about this case? So about 3 weeks later, Zhang and colleagues presented it at the American Society for Reproductive Medicine. They talked that it was Jordanian parents, that mom was heteroplasmic for mitochondria, pathogenic for Leigh's disease. She had previously had 4 miscarriages, as well as 2 children who had died in childhood. This procedure then was performed in Mexico. There was a claim that IRB was approved, that informed consent was obtained, but actually Mexican law doesn't allow germline manipulation, so it's not clear what IRB approved it. They used meiotic spindle transfer was performed on 5 eggs. They chose spindle technology and not pronuclear for religious reasons. They didn't want to create embryos that would be intentionally destroyed, although what you're going to see that all were fertilized. So we do have 5 fertilized and 4 developed into blastocysts, but 3 showed chromosomal abnormalities and were discarded. So it's interesting that they didn't want to use pronuclear because it created embryos specifically for destruction, but even though these 4 were not created specifically for destruction, 3 were still destroyed. One was a 46XY, and that was implanted and gave birth to the healthy boy that we saw the picture of. Interestingly, the average transmission rate in the biopsied blastocyst was about 5%, which according to Egley and colleagues is actually quite high. There was no data about the mitochondrial DNA haplotype matching. And again, and we have no knowledge or data about the egg donor, but if the egg donor were to have come from Mexico, it may be that they're very different mitochondria. And so we have this whole issue of the nuclear mitochondria mismatch and what that might mean. And again, the answer is a big unknown. What else is known or unknown about the pregnancies using mitochondrial transfer and what's known about the children born? So the first-in-kind case in Mexico, just to put it back in perspective, Mexico's general health law prohibits germline manipulation, as well as the U.S. Jordan doesn't have a policy. We do not know who the donor is. We don't know if there's mismatch between the mitochondria and nuclear DNA. So there's just a lot of unknowns, and there's a lot of reason to realize that this is totally unregulated because there is no structure in place for planned follow-up. So it's actually interesting that Dr. Zhang had attempted pronuclear transfer in 2003. And this only gets publicized a month before he's going to announce the birth of this Jordanian couple's infant born by mitochondrial replacement. It was actually reported as an abstract back in 2003. And what was written in 2003 was that there was a 30-year-old nulla gravida female, had 2 failed IVF cycles characterized by embryo arrest. And so they did pronuclear transfer and created a triplet pregnancy, all of which were lost during the pregnancy. One due to fetal reduction, because they thought that trying to be pregnant with twins was risky enough. Fetus B at 24 weeks due to premature rupture of membranes and died from respiratory distress, and fetus C died at 29 weeks in utero due to intrauterine demise due to prolapsed cord. According to Zhang and colleagues, the studies showed that all 3 embryos actually had heteroplasmy, having 2 mitochondria from the 2 different sources, so the intending parent as well as from the egg donor. And Zhang told the press, quote, he had delayed publishing the paper because of the heat around the issue at the time. So where are we now? Well, we're celebrating the first child appears to be healthy, although most scientists and ethicists express concern that there's no system in place for following this child literally for years, decades, and even first and second generation progeny, although again, because this is a male, really, it should stop after the first generation. In the UK, in December of last year, the HFE approved the use of mitochondrial donation techniques for carefully selected patients. And so a clinical trial should be starting shortly. In the US, permission is unlikely in the short term because we also have, not only do we have no system for regulating and for oversight, but the Dickey-Wicker Amendment, which is going on its 20th anniversary, prohibits public funding of human embryo research, which means that if it's going to be done here in the US, it's all going to be done privately with, again, lack of oversight and regulation. So let me conclude by just saying ethicists in the US and UK have concluded that mitochondrial replacement technology is, quote, not unsafe. The UK trials are set to begin. There'll be no gender exclusion, so we will have issues of baby girls being born and needing to follow them for multiple generations. When, if US trials are permitted, it'll initially focus on male embryos. There is a lack of consensus among physician scientists whether we're ready for first-in-human clinical trials, although it's going to make it hard to proceed with caution given the first success that was published back in September by Zhang and colleagues. But that doesn't mean that we shouldn't be proceeding very slowly with caution. And clearly we're going to need long-term follow-up of these children and their children and grandchildren. An international registry would be ideal. So on that note, I have some documents that people could use if they want to understand this issue in more depth. And I'm done and ready to take questions, John.
Great. Why don't we leave that slide up so that anybody who wants to write those down and look up a little more information can do that. For the people online, remind you, there's a chat box in the lower right-hand corner of your screen. If you have a question or comment, just type that in there. Let me start with 2 comments. Well, 3. First, I thought your definition of really recent was since you graduated from med school. Is that?
That's what makes people young.
Okay. A lot of this seems to have parallels to the debates about in the early days of IVF. That is, everybody feared that it wouldn't be safe. Bioethicists advised proceeding with caution or not doing the first baby. The first baby was born and was very cute, and the technology took off, again, with no federal oversight and no federal funding. So the lack of federal funding doesn't stop things from going forward. It just stops them from going forward in a responsible way. Do you think that's what's going to happen here?
Yes, and in fact, the parallels are also perfect because the UK is 10 years ahead of us in much of this research, and they were with IVF as well. So how it differs from IVF is that you're actually, because the technology of removing the karyoplast and then having to refuse it back is using some chemicals that haven't been known. But again, it is in many ways just very similar to the whole IVF story. And of course, we really don't have the end of the IVF story either because, right, we do know that Louise Brown has had a healthy child. But again, that child will have issues in the future none of us really know. I mean, you have to always think of the DES story, right, where women were given DES in order to prevent miscarriage, and it was their daughters who ended up having vaginal cancers, not them. So, you know, what's in store? We're still trying to understand all the results of IVF. Difficult because we don't have a registry, so we only follow those who are willing to be followed. And I think we will have the same story here as well.
But a big difference is, at least to the extent that this is being used to treat diseases rather than mitochondrial diseases rather than infertility, that the potential benefits are very different. Leigh's disease is a devastating neurologic condition. So my guess would be most people who heard your talk but thought they were at risk of having a child with Leigh's disease would say, yeah, I understand the risks. I have much greater risk of having a child with Leigh's disease.
So I agree, although women who have infertility view that as serious a disease as having an affected child. If we were only thinking about using it for mitochondrial diseases, it would be a very small market. So I think just like IVF took off, that at first it was used for young women with infertility problems, it's now being used for older women and things of that sort, especially with donated eggs and things of that sort. So this is going to allow people to have that genetic relationship, and I think you're going to just see that it's going to really take off in the infertility world.
Even though it doesn't seem to work very well.
Well, no. So what didn't work very well was just pushing the cytoplasma. We don't know what will happen when we take the full donor egg cytoplasma and just throw in a new pronucleus.
Okay.
So it's possible that it will be an absolute perfect cure-all for infertility. We really don't know that. We also, one of the biggest differences is because of this, even though it's only 37 genes in that mitochondrial DNA, the fact that we have no idea what risks of the interaction of nuclear and mitochondrial DNA creates a whole new unknown that doesn't exist in normal IVF.
A couple questions online.
So a couple of them are kind of factual questions that you can probably answer quickly, but the first one actually kind of follows up on that. How common are mitochondrial diseases in terms of
So supposedly it's about 1 in 400 women can have some abnormal mitochondrial DNA. The issue is actually, it's interesting because some mitochondrial diseases occur because of some of the nuclear DNA that interact with the mitochondrial DNA. So this methodology will only treat those mitochondrial disorders that are occurring from the cytoplasmic DNA. And so it's an even smaller percentage, probably closer to about 10 to 15% of that 1 in 400. So it's pretty rare is the answer.
Okay, great. And then a factual question about comparing the regulations in the UK to the US. What are the regulations that the UK uses when creating human embryos that will eventually be destroyed? And then following up, why doesn't the US have regulations? Not sure which.
So the UK has a whole system where you have to get permission and you have to justify every embryo that you're going to create and then destroy. And so it's given to centers and clinicians who have incredible expertise and have a lot of preclinical data and things of that sort. So they actually have, so all research that's going to involve the creation of embryos is going to go through the HFEA. So they have a whole regulation system, and it's at the national level for the UK. Why don't we have it? Well, in part because of not federally funding it means that it's all in the private sector, and so therefore it can avoid regulation.
But why don't we federally fund it?
Run for Congress, John.
We have a couple more online and encourage others. The next question says, to what extent do you feel that safety data generated only on males would be applicable or generalizable to female offspring? Do we risk exclusion of certain populations on the basis of risk, scare quotes, think children excluded from trials?
So, first of all, the UK, which is already starting or will be starting very shortly, is not going to have a gender exclusion. So we're going to be able to get some data. But we have to remember, so the data to show that the embryo is healthy and that the child is healthy, I think if we have males, we could probably say it's going to be healthy for females. The real risk with females is then when they go to reproduce, they are now reproducing and they're passing on that replaced mitochondria as well as their nuclear DNA. And that's the big unknown. So I'm not sure that it's a real problem at time 0 for the first generation. It's generation 2, 3, and 4. And we won't have any information. So eventually we're going to need that. But realize that if we start those experiments today, right, and those babies then are born in 2018, that it's going to be like 2030 before we're going to have the first babies born from women who were born from this technology.
Hopefully it'll be a little later than that.
I gave him 22 years. I was being
That was
optimistic.
12, 18 to 20,
Oh,
30.
sorry. Thank you. 2040.
40.
So it's a real long time in the future. And I mean, so one of the advantages of the preclinical data in animals, right, is that, mice have a much shorter period of going from babies to adulthood than humans do.
But the data from mice will never be enough.
No, and particularly because the mice we use are so inbred that we're really also not going to understand some of the issues. And some of the animals have had problems and some haven't. And, we're trying to understand why in some animals it's a problem, having this mismatch, and why in other animals it's not. And we just don't understand any of this at this point.
So given that, if you were on the UK Commission, would you say you only get to do 10 and you have to wait till they have babies before we approve it for more?
No, I don't think we're going to be able to. I think that might be overly cautious. I think they might do 10 and wait at least several years to see that these kids are at least healthy and, do some research on, what's going on in these kids. I don't think I don't think anybody's willing to wait 25 years before they do the next batch of 10. What I'd like to see, though, is that even if we proceed, that we really stick with for serious mitochondrial diseases, like you said, before we start expanding it to things like IVF for infertility issues. There's also a third group that can happen. So we know these are called, quote, the batteries of the cell. And so one question is, could we use it for enhancement? Would you want to have the mitochondrial DNA of a Michael Jordan, per se, right? So his mother's mitochondrial DNA might be really, really valuable and really, really good. Now, we don't really know whether those batteries are really what give you exercise tolerance and things of that sort, although we did see from the mice data that there is some decreased mice exercise tolerance due to this technology. Now, whether it's because they picked a bad source of mitochondrial DNA or because the nuclear mitochondrial disjunction has led to problems. So I don't know if you really want Grandma Jordan's
Another
mitochondria.
unknown.
Exactly.
You have a question, Andrew?
I know, she answered it.
Okay.
Next question from online asks, what do you think of potential application for diseases with features of mitochondrial dysfunction? Examples including Alzheimer's disease, Parkinson's disease, and diabetes.
Yeah, so again, that gets into the into the realm of enhancement and things like that. So we don't know because we really don't fully understand the absolute function of these mitochondrial DNA, separate as well as in conjunction with the nuclear DNA. So I don't know, but that's why I said there are 3 levels. There's for mitochondrial diseases, for infertility, and then for a much wider range of disorders or even enhancements.
Maybe beyond the question of success, though, what do you have any hypotheses or predictions, I should say, of how this will be attempted or trends that we can expect to see in that particular area? Is it?
Well, as I said, I'm hoping that we stick with mitochondrial disorders until we learn a lot more before we move to the next 2
Do you think that will be the case, though? Hopes aside.
Well, so in an unregulated system, the market will determine what will be done and won't be done, and that's scary.
I'd like to get follow-up from whoever asked that question, too, on what they would imagine for the use of mitochondrial transfer for Alzheimer's or Parkinson's. Mm-hmm. Would it be at the time of conception, or would it be treating people who are already symptomatic? And if so,
and of course, the idea
that?
of treating people who are already symptomatic, or even taking all 50-year-olds to try to replace all of our mitochondria is billions and billions of cells, so it's going to be
impossible. With
right
current
now,
technology.
Correct, with current technology, where will be...
But if the person who asked the question has thoughts on that, type them back in for us.
Yes, please do, and signal that you're the person following up on that. Next question, do you have any information about research or progress in these areas in countries other than the UK and the US and Mexico?
Yeah, so no, not that I have seen.
All right, that was quick. Do you expect to do to see research emerging on species somewhere between mice and primates, such as rabbits?
I don't know is the answer. You would I'm not sure what benefit it's going to get, because no matter how many preclinical studies we do, the first in humans and really following in humans is going to be just so different. And understanding, again, it's not just about the mitochondria, it's that mitochondria nuclear interaction. And let's say it had personality effects. I don't know how you measure personality effects in mice or rabbits. So I think we need to be eventually we need to be testing it in humans if that's what we want to see what's going on. So I think there's just a limit to how much we can learn from the preclinical, and I think that's why the UK has said it's not unsafe, and they're willing to take the next step.
Back to the ethics here. The next person asked, what about parental rights? If 3 people contribute genetic material, then how can we say that any of the 3 could be excluded, presumably be the decisive decision maker who gets to keep everyone else from weighing?
So that's going to require contracts if we're going to exclude the mitochondrial DNA provider, right? And we already see that with donated eggs and donated sperm, that contracts are written up very specifically of who is going to have parental rights. So I think there's some degree of experience with that as well. It was interesting that you had the 3 options of how you were going to sort of explain this away, and that both the US and the UK ethics committees have both said we're not willing to, quote, call that the donation of mitochondria a parent, quote unquote. So at least the consensus from those 2 reports, which are the most thoughtful, at least to date, have argued that the mitochondrial DNA is not, is just going to be considered a genetic source and not a parent. And I'm going to argue that I don't really care about any of the genetics, that I'm going to argue that parents are the people who raise the kids. They're the ones who are up at 3 a.m. when the kid's sick.
So what would the default be if someone didn't have a contract or didn't have a properly constructed contract?
So it'd be really hard to prove that you were the mitochondrial DNA donor when you think about it, because if we really are all descended from, so few mitochondrial parents, Eves, right? Hundreds of us should be able to claim that we were that mitochondrial donor. So it's actually going to be even that type of difficulty of being able to prove that you are the, quote, mitochondrial donor.
And in that sense is like most forensic testing. That is, you can prove who's not.
Correct.
But you can't prove for sure who is.
Yeah, exactly.
Let me come back to the question of whether this is germline alteration. I mean, you gave 3 sort of arguments for why it's not. Tell it, where do you stand on it? Is this a germline manipulation, a germline alteration? Is it not germline at all?
So the mitochondria
And does it matter?
Well, so the second question is probably more important than the first question, right? So I think it is a germline manipulation. It's a transfer. You can use that language, or it's a manipulation. You're replacing one set of mitochondria DNA. Now it's 37, and some people are going to say to me, 37 divided by 25,000, it's less than 1%. Meanwhile, that pregnancy wouldn't have gone to term without those 37. So they're quite important, 37. So even if I'm willing to say it's germline, and I am willing to say it's germline, I'm not willing to give it the status of parenthood.
So would giving a pregnant woman who has cancer a potentially teratogenic drug also be germline manipulation?
It's only germline if we're then removing her eggs to store them for future generations, right?
Well, what if she goes on to get pregnant naturally? Her cancer is cured, but we know the drug could have an effect on her gametes.
Right. So we poisoned her gametes, is your point. Does
But
that make them? No, because then the air we breathe is changing. We're having epigenetic changes in all of our cells. So at some point, you just can't say that everything is part of your genetic code.
Or you say it is.
It is. Fair enough.
And therefore, we're doing germline manipulation all the time. This is just more deliberate.
I'm not willing to say that environment is germline manipulation. I see where you're taking it. I think it's...
Okay.
It is epigenetic manipulation, and so that raises issues as well.
Or the new exon skipping drugs, and there's all sorts of non-reproductive interventions that we do that have an effect on
Reproduction.
Yep.
I believe the person who asked us the earlier question has gotten back to
Good.
us. I think this is the person. So again, the question earlier was, what do you think of potential application for diseases with features of mitochondrial dysfunction? And they gave Alzheimer's, Parkinson's, and diabetes as examples. They say now, I suspect it will be driven by family history. My cynicism suggests that the bigger population or market will drive this as opposed to treatment of mitochondrial diseases. Just look at personal genomics, sales pitches for DNA, diet, etc.
So it could be marketed to people with a strong family history of Alzheimer's, saying, you don't want your kids getting your faulty mitochondria. Come to our mitochondrial transfer center, and for a mere $14,000, we will give you better mitochondria and lower your risk of Alzheimer's. You'll lower your child's risk of developing Alzheimer's.
The problem is that, at least for right now, that would be a false claim, only because we don't know whether the disjunction between the mitochondrial and the nuclear DNA might not cause even more serious diseases at an earlier age. And so I would hope, if we still have an FDA, that at that point that we would be able to say that these are false advertisements.
You're in a red state now, baby. Be careful. I wouldn't call that cynical, by the way. I'd call it entrepreneurial. So go for it.
And the greater question is whether we'll still have facts and whether they'll still matter at that point. But of course.
Now.
The next question says, approximately how much more advanced is the UK in mitochondrial transferring technologies compared to the United States? Could the United States rapidly increase production of mitochondrial transfer technologies if various regulations were impeached?
Lifted.
So, the interesting thing when you go back to IVF history is the brain drain that occurred because you weren't allowed to do it here in the U.S., that U.S. scientists were going to both the U.K. and Australia, where there was regulation, but there was oversight, but it was still being permitted. So right now, there's one center in the UK that's sort of the leader in the field, and even the researchers here in the US would all agree with that. It's experience and practice at manipulating these eggs, which is quite difficult, and that's why the comment by Egley and crowd, who are currently in New York, made the comment that 5% is a high percentage, in that, had it been done in the UK, it might have only been 1 or 2%. So, manipulating, taking out that karyoplast is not just sort of, sucking it out with a straw. It's pretty impressive techniques, and we know that in the IVF world, that different centers have much different success rates based on their reproductive endocrinologists and the scientists involved. So, yes, I think the UK is further along, and how much further along? Maybe even more. As it becomes permitted, we might see again a brain drain from here going into the UK.
And isn't there approved protocols or protocols that are being considered? Are they looking at the effect of a better match?
I haven't seen any of the protocols. I don't know, again, so I haven't seen nothing that I've seen online yet talks about that.
There's time for one more question. Vince.
Yeah, so I'm trying to think about what happens in the risk calculation when you do this procedure. So presumably natural selection is...
I don't think we're getting you. Start over.
Okay.
Try it. There we go.
I have so many microphones. This really must be important. So presumably natural selection has preserved some level of compatibility between the mitochondrial DNA and the nuclear genome and the mitochondrial genome, I think. But every time you create a new embryo, you've got half of the nuclear genome coming in from the male, and so you always run some risk of some incompatibility, right? And so I'm wondering, to what extent does this procedure elevate the risk of a mismatch between the mitochondrial DNA and the nuclear genome?
So one of the things we also have to remember is that there's imprinting. So one of the things that amazed me in my post-medical school years is that the DNA, the nuclear DNA, know whether they came from your mother or your father. And so different diseases in the same chromosome are different depending on whether it came from mom or from dad. So the fact is that the nuclear DNA of the intending mother generally is matched to the mitochondria, even if the father's nuclear DNA is different and always changing, as you're pointing out, from generation to generation. So I think that is part of the issue, that these mitochondrial DNA have already imprinted into the woman's DNA, and now if to whatever extent the imprinting affects health, well-being, et cetera, will no longer be there.
Thank you so much. We have to wrap this up for today. A reminder, next webinar, March 27th, James Mumford is coming to town. April 3rd, Larry Churchill. So come back and join us for those two. Pharmacogenetics and Personalized Medicine Conference on April 6th and 7th, right here at Children's Mercy. Thanks for joining us today.